This is for Dr. Chen and Dr. Banwell. Can you talk about the likelihood of more IVIG SCIG efficacy studies for adults and pediatrics?
I think that IVIG does work, and we think that SCIG works as well. Dr. Serturkus actually led a small case series of about 5 or 6 patients that responded very well to SCIG. Obviously, that's convenient because you don't need to have the infusions, and you can do it, once a week. There's multiple other studies in other diseases where it has been shown that SCIG is fairly equivalent to IVIG, and so we could probably extend what we found in IVIG and it being fairly effective in MOGAD, likely that SCIG will work. Obviously, the ideal would be future randomized clinical trials, IVIG or SCIG compared to placebo. We'll see if that comes around. That'd be wonderful. That would give us sort of the ultimate answer.
Yeah, I think, as someone who treats children, and one of the biggest challenges of treating children is they're not particularly fond of needles or infusions. Monthly immune globulin at a day medicine center is a day off work for a parent, a day off school for a child, almost invariably. And so, that has a significant impact. The plus side of immune globulin therapy is it's very safe. It does not compromise their ability to fight infections in the community, and in actual fact, they get a little bit of community immunity. So one of the things parents tell me repeatedly is my child hasn't had a serious cough, cold, or infection since they started immune globulin. And since we think infections may trigger MOGAD relapses, there's a variety of reasons why IVIG has been so popular with families. The two things that I would comment, and many of the families that I work with have shared and have taught me this. One is if I think the patient is going to stay on monthly immune globulin as their strategy, and this is particularly the younger children with relapsing MOGAD for whom subcutaneous isn't necessarily better. It's still a needle under the skin and they're not particularly keen. We do put in ports, so a secure line access for these children. I initially hesitated to do that, but the psychological impact of a difficult IV access every month for small children is huge. And for families where we have gone with putting in a port line as a secure access, so it's, you put the cream on, they hardly feel it when the line goes in. Every single one of those families has told me it's been game-changing, and the mental health of their child has been significantly better. So I think in the right situation, that has gotten around the subcutaneous advantage for the younger children. For my teenagers, they love the subcutaneous option. They do it themselves. I have one patient who starts it on her bus in the morning and finishes it by the time she gets to high school. It's just, literally, she just does not want to miss the bus. So she just does it on her own. So I think, and I think it does work. So obviously, with respect to a trial, my last comment would be, I don't know in relapsing disease that we'll be able to do placebo trials. I think given that the morbidity of MOGAD relates to the attack itself, it's a tough situation. So I think there'll be comparator trials, which is challenging because that will just be looking at whether something similar or maybe better. But having someone experience relapses as a placebo is a really hard thing to do, and it's the right study for the best data, but it's a very difficult model to really actually consider for relapsing patients.